Hello, and welcome to this walkthrough of the decision memo for implantable defibrillators accompanying the National Coverage Determination for Implantable Cardioverter Defibrillators, or ICDs. The walkthrough will also use portions of the actual Medicare National Coverage Determination for implantable automatic defibrillators and the decision memo for cardiac pacemakers. The purpose of this walkthrough is to clarify how Medicare coverage is provided by CMS for devices combining biventricular pacing with an implantable cardioverter defibrillator, also known as cardiac resynchronization therapy defibrillator, or CRT-D devices. We will also briefly discuss pacing-only cardiac resynchronization therapy devices, or CRT-P devices. This video addresses CMS coverage and not FDA-approved indications. FDA indications, on label, do not always match up with CMS coverage, and it is entirely possible that the CMS policies we are discussing limit coverage beyond the FDA label. Before we begin, it is important to emphasize that Medtronic does not make any representations or warranties in connection with the information presented herein. These materials in this walkthrough are provided for informational purposes only and are not intended as a guarantee or promise as to coverage and associated reimbursement amounts. This information does not replace seeking advice from your compliance and reimbursement staff and/or your payer. The provider of services is ultimately responsible for compliance. The latest version of the Implantable Cardioverter Defibrillator National Policy became effective on January 27, 2005, and remains in place today. National policies, formerly called National Coverage Determinations, or NCDs, are normally developed and issued by CMS when the products or services provided to Medicare beneficiaries are high cost and/or highly specialized. Decision memoranda are documents accompanying each national policy that outline how CMS arrived at the coverage criteria included in the policy. These memoranda provide valuable insight into each policy. Please note that local Medicare contractors have the ability to put in place local policies which can provide greater clarity on national policies. And while local policies may not contradict national policies, they may control and clarify coverage for device implants where no national policy exists. Always check with your compliance department and/or payer on the existence of such policies. In order to understand how CMS provides coverage for CRT-D devices, let's start with the decision memo accompanying the ICD national policy. Look at the first page of the document. Please note letters A and B. Many readers may miss the text in letter B, since it is towards the bottom of the page and the document is usually read on screen. As you will see, these documents seem to speak about ICDs and not about CRTDs. Nevertheless, as we will see, they are applicable to CRTDs as well. We will get to that later. The text under A describes the three indications for which CMS determines evidence to be adequate for Medicare coverage of an ICD implant. Also note that the text under B essentially repeats the second of the three indications presented under A, with the caveat of the evidence being less compelling. The indication is the same, but the 9 months becomes 3 months. No additional criteria need to be met for these patients. In short, from A and B, it can be concluded that ICDs are covered for the following Medicare patients: NYHA Class 2 and Class 3 heart failure patients with an ejection fraction equal to or below 35%, who also have either ischemic dilated cardiomyopathy and previous MI, or non-ischemic dilated cardiomyopathy for more than 3 months. And NYHA Class 4 heart failure patients who also meet all CMS coverage requirements for cardiac resynchronization therapy, or CRT. It is very important to note that currently there is no CMS policy on CRT, meaning no CMS coverage requirements for CRT. The implication is that all NYHA Class 4 heart failure patients are covered for an ICD provided the remaining criteria are met. Here it is important to note that these are not the only requirements. Here you see 6 additional criteria that also need to be met. Pay close attention to these criteria, as failure to meet and properly document these criteria is a common reason for CMS to deny coverage. The list of criteria under point 2 requires further attention. Note that the patient must not have had a CABG or PTCA within the 3 months prior to device implant. The patients also must not have had an acute MI within 40 days prior to implant. Criterion 6 is also critical and requires that results of all tests, exams, and other documents proving the patient met all coverage requirements at time of implant are included in the patient record. Another word of caution: many individuals interpret this statement to be relevant only for devices with more than one lead. In practice, this requirement applies to all devices under the policy. Finally, please note requirement number 5, which requires the patient be enrolled in a special registry for coverage to be provided. Your coders and/or billers will need to include a specific modifier on the claim form to show that the patient was registered in the primary prevention database. This specific modifier is not necessary for inpatient hospital implants. Failure to do so is another common cause for denial. So far, we've mentioned ICDs, but what about CRTDs? Nothing here seems to point to CRTDs, and that may be confusing to many readers of the document, leading some to think that this is not relevant for CRTDs. Nevertheless, this policy applies directly to CRTDs as well. This evidence is provided much later in the document. We need to go to page 6 for this. Notice here that even though CMS did not conduct an exhaustive review of CRT evidence when making this policy, it does consider its decisions applicable specifically to CRTDs. We have now established that the national policy applies to single, dual, and multiple lead, or CRT, ICDs. But you may be wondering why CMS does not explicitly state which indications are covered for each ICD device type. Evidence of the thinking behind that is reported on page 28 of the memo. This question came up during the policy comment period. It seems that CMS did consider the merits of having different indications per device type. However, the final decision was to leave exact device selection in the hands of the physician. This paragraph is the source of the language we covered previously to justify medical necessity for CRT-D. If you can provide clinical evidence, for example, peer-reviewed manuscripts of clinical studies or society guidelines, that a dual or multiple lead device is beneficial to a patient who already meets one of the covered indications we have discussed, coverage may be available. Please note that exams and tests proving any additional patient characteristics specific to that indication also need to be included in the medical record. For the recent block HF indication, for example, evidence that the patient also has AV block must be provided. A final and important note of caution: FDA indications on label do not always match up with CMS coverage, and it is entirely possible that the CMS policies we are discussing limit coverage beyond the FDA label. Having walked through the decision memo, looking at the actual policy becomes much easier. Notice that the actual policy spans 7 pages. Some of the text appears in red. This was added by CMS to differentiate the language added after the latest revision of the policy in 2005. Notice that the policy spells out 9 covered indications in total. However, because indication number 7 was replaced by indication number 9, reducing the 9-month requirement to greater than 3 months, there are technically 8 covered indications. The first 5 appear on page 3 of the freely available PDF. The indications most commonly used to provide coverage for a CRT-D device are on page 4. And on page 6, there is indication number 9, which is identical to indication number 7 on page 4, but reduces the 9-month requirement to 3 months. Also note that after indication number 8, a block of additional criteria is introduced. Indications we first reviewed in the decision memo earlier are actually repeated on page 6 again after indication number 9. Importantly, the phrase on justifying the medical necessity of devices other than single lead devices appears twice in the document, once on every additional criteria block, page 6 and page 7. It is also very important to highlight again here that some local Medicare contractors have issued local Medicare policies that may provide additional clarification and documentation tips and/or requirements. Please make sure you check with your compliance department and/or local payer on the existence of such policies. Whew. That was a lot of information, but we are close to the end. Just a brief discussion on CRT-P. Medicare has clarified now that CRT-P does not fall under the National Coverage Determination for pacemakers. This is evident in the decision memo for cardiac pacemakers. This currently leaves CRT-P device implant coverage without a national policy, and this means that coverage for these devices is governed, if at all, at the local Medicare contractor level. In closing, a final reminder that local Medicare contractors have the ability to put in place local policies which can provide greater clarity on national policies. Similarly, local policies can limit coverage for device implants where no national policy exists. Always check with your compliance department on the existence of such policies. Specifically for CRT-P devices, even if there is no national or local policy in place, it is very important to document the medical need for the device and to include in the patient record all exams and tests which evidence the medical need. At a minimum, information on the patient meeting FDA labeling and a guideline-recommended indication or the enrollment criteria of a well-defined and high-quality randomized control trial that reaches its endpoint should be included in the patient chart. The reference to the trial itself can also help. For more information, please do not hesitate to reach out to us. We can be contacted online at rs.healthcareeconomics@medtronic.com. Once more, it is important to emphasize that Medtronic does not make any representations or warranties in connection with the information presented herein. These materials and this walkthrough are provided for informational purposes only and are not intended as a guarantee or promise as to coverage and associated reimbursement amounts. This information does not replace seeking advice from your compliance and reimbursement staff and/or your payer. The provider of services is ultimately responsible for compliance. Additionally, FDA indications on label do not always match up with CMS coverage, and it is entirely possible that the CMS policies we are discussing limit coverage beyond the FDA label. Thanks for your attention.